Shock. 12 General Principles, IM screening tests. Should begin in high risk women at 45 YRS spikes step by step mnemonic for family meeting. General Principles, Pediatrics. Normal physical findings in newborn, dry, flaky, peeling skin of hands and feet is common as skin adjusts to dry extrauterine environment. Pink stains or brick dust in neonatal diapers is due to uric acid crystals. Uric acid excretion is ESP. High at birth and downward arrow ES until adolescence. When adult levels are observed, uric acid crystals are commonly seen during first week as mother's milk is coming in, or in later months with morning void after infant begins to sleep through night. Healthy infants normally lose up to 7% of weight in first 5 days of life due to excretion of excess fluid acquired in utero and during labor. Weight loss more pronounced in exclusively breastfed infants as mother's milk production upward arrow ES gradually to meet infants' demands. Rightward arrow encourage frequent breastfeeding and educate about dehydration. Evaluation of neonatal hydration. Normal urine output. As a general rule, the number of wet diapers should equal age in days for the first week of life. For example, a 4-day-old neonate should have /equals 4 wet diapers per day. After the first week, infants should have /equals 6 wet diapers per day. Birth weight should be regained by age 10 to 14 days. Infants have immature kidneys that cannot reabsorb sodium effectively. Plain water should never be given to infants age 6 months as it can dilute the blood, resulting in dangerous hyponatremia and seizures. Developmental milestones. By 4 months, primitive reflexes E.G. Moro, grasp have already disappeared or beginning to disappear as infant initiates purposeful movement of extremities. Tongue protruding reflex also disappears by 4 mo, allowing co-ordination to ingest food at 4 to 6 mo. Premature initiation of toilet training can prolong the duration of training incontinence ESP. Nighttime is common up to age 5. Children /equals 5 YRS should undergo urinalysis to screen for UTI, DM, and DIG. Normal growth involves periods of rapid increase in weight and length, growth spurts, especially during the first 6 months of life. By age 12 months, a child's weight should triple and height should increase by 50%. Delayed verbal milestones should be assessed with audiologic evaluation. Intraosseous catheter, emergency situation. Rightward arrow when 4 access cannot be obtained. Rightward arrow intraosseous, IO, access should be obtained urgently. IO access benefits over central venous catheter, require less skill and practice. Safer and faster. Cannula is large enough to deliver fluids and medicines quickly and obtain blood samples. Most common site, proximal tibia. Benefits of this site, wide and flat surface at distance from sternum in case cardiopulmonary resuscitation is performed simultaneously. Any large bone can be used though. IO catheter can be placed manually or using a driver. Contraindications to IO placement: infection, E.G. cellulitis, over the access site fracture or previous IO attempt in chosen extremity. Bone fragility, E.G. osteogenesis imperfecta. Although nasogastric fluids are preferred for mild to moderate dehydration associated with gastrointestinal disease, they are not recommended in shock, when the splanchnic circulation is constricted. General principles, surgery. Glasgow Coma Scale. All trauma PTS should be first assessed by GCS, which estimates severity of PTS. Neurological injury for triage, also gives prognostic information when used in conjunction with the PT's age and presence of concomitant adverse clinical findings, such as hypoxia, cardiovascular compromise, upward arrow ICP, and radiographic evidence of midline shift of brain, used to predict the prognosis of coma and other medical conditions, such as bacterial meningitis, traumatic brain injury, and subarachnoid hemorrhage. The GCS is not used to diagnose coma in a patient. Findings used to diagnose coma include impaired brainstem activity, E.G. disruption of the pupillary light, extraocular, and corneal reflexes, motor dysfunction, E.G. decorticate or decerebrate posturing, and impaired level of consciousness. There is no text on this page. Cervical spine trauma. After stabilization of cervical spine, next step is to assess the airway. Unstable lesions above third cervical vertebra rightward arrow can cause immediate paralysis, and lower cervical lesions rightward arrow can damage the phrenic nerve. Cervical spine injuries can be associated with oral maxillofacial trauma, hemorrhage in the retropharyngeal space, and significant airway and neck edema. All could prevent adequate landmark visualization during intubation. Hyponic and hypoxic PT requires emergency airway access. Orotracheal intubation with rapid sequence intubation is the preferred way to establish an airway unless there is significant facial trauma. 4 people are required for this procedure. 1 manually stabilizes the patient, requires firmly holding either side of the patient's head, with the neck midline and on a firm surface, without applying traction. This prevents neck flexion or rotation during intubation. 1 administers induction anesthesia. 1 applies cricoid pressure to prevent passive regurgitation until endotracheal tube placement is confirmed, and 1 places the endotracheal tube. A difficult intubation kit should be available in case the attempt is unsuccessful. Laryngeal mask placement is a temporary measure to stabilize the patient until another airway can be established if orotracheal intubation fails. Nasotracheal intubation blind procedure contraindicated in apneic/hyponic patients. It is also contraindicated if the patient has a basilar skull fracture, as such fractures are associated with a risk of cribriform plate disruption, which could lead to inadvertent intracranial passage of the tube. Due to the risk of carbon dioxide retention, needle cricothyroidotomy is not ideal in patients with head injury who might require hyperventilation to prevent or treat intracranial hypertension. However, it is preferred to surgical cricothyroidotomy in children aged 12 as it is easier to perform anatomically. Tracheostomy no longer a first option for establishing an airway due to its complications. Surgical cricothyroidotomy is preferred over surgical tracheostomy but should be converted to formal tracheostomy in 5 to 7 days if prolonged airway control is needed. Prolonged use of cricothyroidotomy has a high incidence of tracheal stenosis. Ruptured abdominal aortic aneurysm, abdominal pain, hypotension, pulsatile abdominal mass rightward arrow evaluate in operating room with bedside USG. CT scan is performed only in hemodynamically stable PTS with ruptured aortic aneurysm rightward arrow urgent surgery penetrating abdominal trauma, hemodynamically stable in whom injury to hollow viscus or other organ cannot be determined clinically rightward arrow laparoscopy can be performed, hemodynamically unstable rightward arrow urgent exploratory laparotomy. Any penetrating injury in the thorax below the level of the nipples has potential to also involve the abdomen through the diaphragm and is assumed to involve both compartments until proven otherwise. Rightward arrow perform laparotomy in unstable PT. Blunt abdominal trauma. If USG/FAST is not available, rightward arrow peritoneal lavage to detect intraperitoneal bleeding in hemodynamically unstable PT with blunt trauma. Rupture of bladder dome is the only bladder part that can cause peritonitis. Rest of bladder structures would not cause peritonitis. Most common site for extraperitoneal bladder rupture is bladder neck. Plus cervical spine immobilization and 4 fluids. Traumatic amputation. All PTS with traumatic implantation should be treated as candidates of reimplantation in the field. Method to preserve amputated limb/digit. Wrap in sterile gauze, moistened with saline. Rightward arrow place in plastic bag. Rightward arrow place on ice but do not let it freeze. Rightward arrow transport to nearby emergency department. This method prolongs the viability of amputated part by 24 hours. Best candidates: younger patients suffering sharp amputation with no crush injury or avulsion. Don'ts: immerse in water. Rightward arrow makes digital vessel repair more difficult. Place in alcohol or aseptic solution. Rightward arrow chemical injury. Place directly on ice. Rightward arrow cause frostbite and loss of viability. Hypovolemic shock. Pulse rate is the first manifestation of hypovolemic shock due to activation of sympathetic system, which also causes peripheral vasoconstriction. In grade 2, mean arterial BP is normal but pulse pressure is narrowed and BP starts downward arrowing. Skin is cool and moist. Lymphedema. Contents: hordeolum or sty. 3 chalazion. 3 dacryocystitis. 3 conjunctivitis. 4. Viral conjunctivitis. 5 allergic conjunctivitis. 5 atopic keratoconjunctivitis. 5 subconjunctival hemorrhage. 6 keratitis. 6. Contact lens associated keratitis. 6 HSV keratitis. 6 herpes zoster ophthalmicus. 6 corneal abrasion. 6 high velocity injury to eye. 7 sympathetic ophthalmia. 7 uveitis. 7 anterior uveitis, iritis. 7 episcleritis. 7 retinitis in AIDS patients. 8 HIV retinopathy. 8 CMV retinitis. 8 HSV and VZV retinitis. 9 toxoplasmic chorioretinitis. 9 syphilitic chorioretinitis. 9 endophthalmitis. 9 postoperative endophthalmitis. Endophthalmitis. 9 candidal endophthalmitis. 9 diabetic retinopathy. 9 hypertensive retinopathy. 10 non-ketotic hyperosmolar syndrome, NKHS. 10 retinal detachment. 10 amaurosis fugax. 11 central retinal artery occlusion, CRAO. 11 central retinal vein occlusion, CRVO. 11 optic neuritis. 12 vitreous hemorrhage. 12 choroidal rupture. 13 cataract. 13 glaucoma. 14 acute glaucoma. 14 acute angle closure glaucoma. 15 open angle glaucoma. 15 macular degeneration. Degeneration. 16 atrophic dry macular degeneration. 16 exudative/neovascular wet macular degeneration. 16 vision assessment or screening. 16 strabismus. 17 pseudostrabismus. 17 trachoma. Trachoma. 18 optic glioma in neurofibromatosis type 1. 18 retinoblastoma. 18 ophthalmology, IM hordeolum or sty, common staphylococcal abscess of eyelid, painful, localized, small swelling along margin of eyelid. Management, mostly responds to warm compresses. Internal, INFs of meibomian gland. External, INFs of hair follicule. If resolution does not begin in 48 hours, rightward arrow incision and drainage performed may need antibiotic ointment such as bacitracin or erythromycin chalazion, initially painful swelling that progresses to a nodular rubbery lesion. Chronic granulomatous condition develops when a meibomian gland becomes obstructed. Persistent or recurrent chalazion may be due to meibomian gland carcinoma, sebaceous carcinoma. Additionally, basal cell carcinoma, most common tumor of lid margin, frequently presents as a solitary nodule on the lid margin, and may initially be clinically difficult to distinguish from a chalazion's. Management, histopathologic examination to rule out malignancy. Direct steroid injection and incision and curettage are used in symptomatic patients who did not respond to other modes of treatment after histopathologic analysis has ruled out malignancy. Dacryocystitis, infection of lacrimal sac, usually in infants and adults. 40, acute, sudden onset redness and pain in medial canthal region, sometimes, purulent discharge is noted from punctum. Few present with fever, prostration, and upward arrow leukocyte count, causative organisms, S. aureus and beta, hemolytic streptococci, Rx, systemic antibiotics. Conjunctivitis. Edema of eyelids. Viral conjunctivitis, most cases due to adenovirus, usually in late summers and early fall. Outbreaks common in children and caregivers, last several days and usually self-limited and usually preceded by typical nasopharyngeal symptoms. Rarely bacterial superinfection occurs. Rightward arrow, more severe pain and purulent discharge. Rightward arrow requires topical antibiotics. Uncomplicated, is treated only symptomatically. Role of mast cell stabilizers is unclear. Prednisolone drop CI. Allergic conjunctivitis, acute hypersensitivity reaction, causes exposure to environmental allergens like animal dander, dust, and mold spores. Reagin, I.E. IgE, mediated, usually FH or personal H/O. Atopic disorders such as asthma or seasonal allergies, management, usually subsides in 24 hours even without treatment. For persistent or recurrent SX, can be treated with a variety of topical agents including antihistamines, vasoconstrictors, mast cell stabilizers E.G. olopatadine and azelastine, and artificial tears, available OTC or prescription med. Oral antihistamines less effective for acute episodes but can be helpful if taken seasonally, prior to allergen exposure. Atopic keratoconjunctivitis, severe form of ocular allergy, most common symptoms, itching, tearing, thick mucus discharge, photophobia, and blurred vision. It can be differentiated from AC by more severe symptoms with a prolonged course, potential visual impairment due to corneal involvement, and thickening of the eyelids and surrounding skin. Subconjunctival hemorrhage, red eye without any symptoms, completely benign condition. Risk factors, results from rubbing eye vigorously, violent coughing spells. HTN episodes or coagulopathy, workup, usually results from minor bruising. Rightward arrow, no workup needed. Management, observation. Best treatment usually resolves in 24 to 48 hours. Occasionally PTS have upward arrow BP, which requires lowering keratitis. Contact lens associated keratitis, painful, red eye, opacification and ulceration of cornea. Most cases are due to Gram-VE organisms such as Pseudomonas and Serratia, but can be due to Gram+VE organisms as well as fungi and amoebas. Medical emergency. Can lead to corneal perforation, scarring and permanent vision loss if not addressed promptly. Management. Remove and discard lens. Topical broad-spectrum antibiotics. HSV keratitis, most frequent cause of corneal blindness in U.S., usually occurs in adults. C/F, pain, photophobia, blurred vision, tearing and redness. H/O prior episodes may be present. Precipitating factors for recurrences: excessive sun exposure, outdoor occupation, fever, immunodeficiency, examination, corneal vesicles and dendritic ulcers. Most common presentation, characteristic. DX, primarily clinical, although epithelial scrapings will show multi-nucleated giant cells, RX, oral or topical antiviral therapy. Effective herpes zoster ophthalmicus, caused by VZV, virus remains latent in trigeminal ganglion. Rightward arrow immunosuppression. Rightward arrow virus travels via ophthalmic branch to forehead and eye. SX, fever, malaise, and burning, itching sensation in the periorbital region. Examination, vesicular rash in distribution of cutaneous branch of first div. Of trigeminal nerve. Conjunctivitis and dendriform corneal ulcers characterize eye involvement. RX started within 72 HRS after eruption with high-dose acyclovir. Rightward arrow downward arrow development of complications. Corneal abrasion, presents with severe pain and photophobia. Usually a history of trauma to the eye. Slit lamp examination with fluorescein will reveal the corneal abrasion. High velocity injury to eye, foreign body sensation, photophobia and excessive lacrimation, most commonly associated with drilling, hammering, grinding etc. In contrast to low velocity, high velocity injury has greater probability of globe penetration and intraocular foreign body formation. Even if initial presentation is subtle, clinician should be cognizant of such probability. Gross examination, abrasion or foreign body may not be visible, fluorescein application following Wood's lamp or preferably slit lamp examination most reasonable next step after gross exam, if a foreign body not demonstrated and a strong suspicion remains rightward arrow CT or USG can be considered. MRI is contraindicated for the diagnosis of a foreign body rightward arrow since it can dislodge the foreign body because of the strong magnetic field. Topical antibiotic applied after removal of FB. Sympathetic ophthalmia, also known as spared eye injury, characterized by immune-mediated inflammation of one eye, the sympathetic eye, after a penetrating injury to the other eye. The typical manifestation is anterior uveitis, but panuveitis, papillary edema, and blindness may develop. Pathophysiological mechanism, uncovering of hidden antigens. Some antigens contained within the eye are protected from immunologic recognition by natural barriers. Breaking these barriers results in the uncovering of hidden antigens. An immune response against these antigens can involve autoantibodies as well as a cell-mediated reaction. Uveitis presents with moderate pain and blurred vision. Cornea may be hazy, the anterior chamber shows flare and cells on slit lamp examination. The pupil is constricted with a poor light response. Anterior uveitis, iritis, inflammation of anterior uveal tract ESP. Iris, presentation, may have associated conjunctival inflammation adjacent to cornea, paralimbal injection, but cornea itself is usually spared. Corneal stromal edema may be present. Discharge uncommon, if present, not profuse. Usually significant pain, miosis, and photophobia. Visual loss may be present. Examination keratic precipitates mutton fat, iris nodules, associated with HLA, B27 related conditions. Episcleritis, common cause of red eye, distinguished by its localized or patchy distribution, generally mild. Associated pain and discharge, may be associated with rheumatoid arthritis and other autoimmune disorders, but many cases are idiopathic, usually self-limited and does not affect vision or involve the cornea. Retinitis in AIDS patients, occurs in approximate half of AIDS PTS, usually a complication of opportunistic infection. Most are believed to be reactivation of previous infection. HIV retinopathy, cotton wool retinal lesions that are rarely hemorrhagic, usually resolves over weeks to months, usually no floaters or blurred vision. CMV retinitis, most common serious complication of HIV PTS. CMV causes asymptomatic initial infection but causes lifelong latent infection. PTS with significantly compromised cell-mediated immunity, E.G. Advanced HIV with CD4 100/MM3, rightward arrow reactivation of CMV. Rightward arrow may cause viremia or end-organ disease. CMV retinitis, characterized by full-thickness retinal inflammation that moves centripetally along the vasculature. Rightward arrow edema and scarring, C/F, blurred vision, floaters, and photopsia, sensation of flashing lights, painless, not usually associated with keratitis or conjunctivitis, lesions near fovea and optic nerve. Rightward arrow can cause blindness, scarring. Rightward arrow upward arrow ES risk of retinal detachment, DX, fundoscopy, yellow, white, fluffy, hemorrhagic lesions along the vasculature. Blood tests for CMV, polymerase chain reaction, not sufficient for diagnosis as viremia may develop independently of end-organ disease. RX, usually treated with oral antivirals, e.g., valganciclovir. If lesions are near the fovea or optic nerve, intravitreal injections are added. All patients should be initiated on antiretroviral therapy, usually 2 weeks after beginning CMV treatment, to prevent recurrence and progression. HSV and VZV retinitis, both VZV and HSV cause severe devastating intraocular inflammation, severe, acute retinal necrosis. In an immunocompromised individual, HSV retinitis may be characterized by rapidly progressing bilateral necrotizing retinitis, referred to as the acute retinal necrosis syndrome. Initial symptoms, keratitis, uveitis and conjunctivitis with eye pain, followed by rapidly progressive visual loss. Funduscopy reveals widespread, pale, peripheral lesions and central necrosis of the retina. HSV infection of the eye is the most common cause of corneal blindness in the United States. Toxoplasmic chorioretinitis causes eye pain and downward arrow vision. Retinal lesions occur in non-vascular distribution. Syphilitic chorioretinitis usually presents with uveitis and diminished visual acuity, almost always occurs with syphilitic meningitis. Endophthalmitis, invasive infection of globe, bacterial or fungal, due to disruption of external surface of eye, e.g. trauma, may show conjunctival irritation as well, usually have purulent haziness of ocular contents and may have layering, out of pus in anterior chamber, hypopyon, postoperative endophthalmiti hypopyon equals pus in ant chamber, most common form of endophthalmitis, it usually occurs within 6 weeks of surgery. Hyphema equals blood in ant chamber. It is an infection within the eye, particularly the vitreous. Patients usually present with pain and decreased visual acuity. Examination, swollen eyelids and conjunctiva, hypopyon, corneal edema, and infection. The vitreous can be sent for gram stain and culture. Rx, based on the severity, intravitreal antibiotic injection or vitrectomy is done. Candidal endophthalmitis can occur ESP. With disseminated candidiasis, patients with Candida fungemia who appear sick should be evaluated by an ophthalmologist for possible endophthalmitis. Diabetic retinopathy can occur in both insulin-dependent and non-insulin-dependent DM, has 3 types. 1. Background or simple retinopathy or non-proliferative, consists of dilation of veins, microaneurysms, dot and blot hemorrhages, hard exudates, and retinal/macular edema. Rightward arrow blurred vision. 2. Proliferative retinopathy, with cotton wool spots. 3. Proliferative or malignant retinopathy, consists of newly formed vessels. PTS are usually asymptomatic initially, despite early signs of retinopathy, e.g. microaneurysms, visual impairment occurs with development of macular edema. Management, argon laser photocoagulation is suggested treatment for prevention of complications. Hypertensive retinopathy, acute vision changes like hemorrhages, exudates and or papilledema. Rightward arrow require malignant BP, DBP 120 to 130. Acute vision loss not typical, there is initially focal spasm of arterioles, followed by progressive sclerosis and narrowing. Funduscopy, copper or silver wiring, findings depend on the severity of retinopathy. Non-ketotic hyperosmolar syndrome, NKHS, can occur in type 2 diabetics in association with recent stressor like URTI, stress. Rightward arrow upward arrow cortisol and catecholamine. Rightward arrow hyperglycemia, serum glucose 600 mg/dl, without ketosis. Rightward arrow glycosuria. Rightward arrow diuresis. Rightward arrow dehydration and serum hyperosmolarity, often 320 mosm/L, altered consciousness ranging from confusion to coma, main symptom in NKHS. Blurred vision due to myopic upward arrow in lens thickness and intraocular hypotension. 2 * to hyperosmolarity. Retinal detachment, separation of layers of retina, usually occurs in 40 to 70 UPTS, C/F, photopsia, floaters, curtain coming down over my eyes, inciting event usually occurs months before retinal detachment. Risk factors, myopia or trauma, e.g. cataract surgery, can cause retinal breaks. Rightward arrow fluid seeps in and separates retinal layers. Ophthalmoscopy, gray, elevated retina, management, laser therapy and cryotherapy are done to create permanent adhesions between the neurosensory retina, retinal pigment epithelium, and choroid. Amaurosis fugax, transient monocular visual loss, sometimes described as curtain falling down, cause, most commonly from retinal emboli from ipsilateral carotid artery, mostly due to atherosclerosis. Rightward arrow. Once clot breaks or displaces rightward arrow, blood flow restored. Rightward arrow. Vision returns. Fundoscopy, depends on cause. Examination may be normal or show zones of whitened retina, from edema, following distribution of retinal arterioles. Rarely, plagues or emboli seen. Workup, non-invasive evaluation of carotids to provide information regarding stenosis, Rx, atherosclerosis treatment. Downward arrow. Risk of stroke. Central retinal artery occlusion, CRAO, it occurs when a severe, abrupt diminution of blood flow through the central retinal artery causes ischemia of the inner retina. Ophthalmic artery is the first intracranial branch of internal carotid artery. Supplies blood to eyes via 1. Central retinal artery. Rightward arrow supplies inner retina. 2. Ciliary branches. Rightward arrow supplies choroid and anterior portion of globe. Emboli can travel to more distal branches, causing loss of only a section of visual field, commonly associated with amaurosis fugax, visual acuity typically 20/800, 6/240, or worse. Fundoscopy, diffuse ischemic retinal whitening, pale optic disc, cherry red fovea, typical but not specific, and boxcar segmentation of blood in retinal veins. Ophthalmic emergency delay in Rx can lead to permanent vision loss. Rx, immediate intervention. Ocular massage dislodges embolus to more distal branch and improves vision. Most rapid medical management and anterior chamber paracentesis to lower IOP may be used. Carbogen therapy, 5% CO2 and 95% O2, or hyperbaric oxygen beneficial if given early. Thrombolytic therapy may be helpful if given in 4 to 6 hours given intra-arterially. Efficacy not systematically studied. Central retinal vein occlusion, CRVO, must be kept on differentials in PTS with acute or subacute U/L visual loss, but usually not as acute as CRAO, characterized by sudden, unilateral visual impairment that is usually noted upon waking in the morning, caused by thrombosis. Risk factors: patients with coagulopathy, hyperviscosity, chronic glaucoma, and atherosclerotic. Risk factors, e.g., age, diabetes, hypertension. Ophthalmoscopy, disc swelling, venous dilation and tortuosity, retinal hemorrhages and cotton wool spots, DX, confirmed with fluorescein angiography. Management: no significant macular edema or neovascularization. Rightward arrow conservatively with close observation. Significant macular edema. Rightward arrow intravitreal injection of vascular endothelial growth factor inhibitors. No treatment is particularly effective, but some may have partial recovery of vision within the first 3 months. Optic neuritis, usually in PTS 20 to 45 females. More commonly affected. Suspect optic neuritis in a patient with central scotoma, afferent pupillary defect, changes in color perception and decreased visual acuity. Remember the association between optic neuritis and multiple sclerosis. The USM loves this topic. Rapid impairment of vision in one eye, rarely both, and pain on eye movement, marked changes in color perception. Afferent pupillary defect and field loss occur, usually with central scotoma. Swollen disc on exam, more common in patients with multiple sclerosis. Such patients will usually give a history of similar occurrences in the past. Vitreous hemorrhage, typically presents as a sudden loss of vision and onset of floaters. Most common cause, diabetic retinopathy. Most commonly occurs in proliferative diabetic retinopathy. Ophthalmoscopic evaluation: fundus is hard to visualize, and even if it is visualized, details may be obscured, floating debris and dark red glow may be seen. Management: immediate ophthalmologic consultation is required for patients with underlying medical conditions. Conservative treatment, i.e., upright position during sleep, which enhances settling of the hemorrhage, is recommended. Choroidal rupture occurs due to blunt ocular trauma. Examination reveals central scotoma, retinal edema, hemorrhagic detachment of the macula, subretinal hemorrhage, and crescent-shaped streak concentric to the optic nerve. The usual complaint is blurred vision following blunt trauma. Cataract, vision, impairing opacification of the lens. Oxidative damage of the lens occurs with aging, risk factors, advancing age, diabetes, smoking, chronic sunlight exposure, and glucocorticoid use. Usually bilateral, but patients may become symptomatic in one eye before the other. C/F, painless blurred vision, glare, and often halos around lights. Loss of nighttime vision is very characteristic. Ocular examination in early cataract formation may show a normal red reflex and retinal visualization, but as the cataract progresses, the red reflex is lost and retinal detail may not be visible, typically follow a slowly progressive course. Treatment is indicated when loss of vision impairs activities of daily living. Definitive treatment is lens extraction with artificial lens implantation. The risk of perioperative complications in cataract surgery is low, and anticoagulants do not need to be held. Glaucoma. Acute glaucoma, emergency condition. Narcotics are used for pain control. Meds to downward arrow intraocular pressure. 1. 4-mannitol first-line osmotic diuretic works immediately. 2. Acetazolamide rapidly downward arrow further aqueous humor production rightward arrow downward arrow intraocular pressure. 3. Pilocarpine applied topically rightward arrow opens canal of Schlemm rightward arrow drainage of aqueous humor. 4. Timolol applied topically rightward arrow downward arrow production of aqueous humor. Contraindicated drugs, mydriatic agents like atropine, causes pupillary dilation rightward arrow precipitates or aggravate glaucoma. Acute angle closure glaucoma, occurs with closure of pre-existing narrow anterior chamber angle. Acute, predominantly occurs in PTS 55 to 70 YRS, usually occurs following pupillary dilation, E.G. In dark, stress or due to drugs, C/F, severe pain, blurry vision, N/V, PE, red eye with steamy/hazy cornea and moderately dilated pupil that is non-reactive to light. Shallow anterior chamber with inflammatory changes, management, ophthalmology consultation. Gonioscopy, gold standard. Ophthalmologist uses a specialized prismatic lens with a slit lamp to visualize the iridocorneal angle. Tonometry rightward arrow reveals upward arrow IOP device is placed against the anesthetized cornea, quantitated pressure is applied, and the resulting indentation is measured. Performed if additional info is needed or ophthalmologic consult is not available. Rx, 4-acetazolamide, with subsequent oral administration, rightward arrow may lower IOP. Permanent cure, offered with laser. Peripheral iridotomy or surgical intervention, iridotomy or iridectomy, open angle glaucoma, prevalence, African, Americans, FH of glaucoma and diabetes. Insidious onset, asymptomatic initially, gradual loss of peripheral vision over years, eventually resulting in tunnel vision, persistently upward arrow ed IOP, pathologic cupping of optic disc. Prevention, annual examination in high-risk populations. Rightward arrow beneficial, beta, blockers such as timolol eye drops are effective in the initial management of the patient. Laser trabeculoplasty is used as an adjunctive measure. If there is a continuous increase in intraocular pressure, surgical trabeculectomy is done. Macular degeneration, usually in PTS 50 YRS. Smoking is also a risk factor. Leading cause of blindness in industrialized countries, pathogenesis, degeneration and atrophy of outer retina, retinal pigment epithelium, Brooks membrane, and choriocapillaries, C/F, may be asymptomatic. Some may complain of U/L or B/L visual problems driving and reading affected first as they require fine visual acuity provided by macula distortion of straight lines such that they appear wavy. Usually initial finding grid test performed to screen for MD progressive B/L loss of central vision. Peripheral and navigational vision are preserved but may become impaired by development of cataracts. Atrophic dry macular degeneration, slowly progressive B/L vision loss, drusen and patchy depigmentation in macular region, exudative/neovascular wet macular degeneration, may be acute or insidious U/L aggressive vision loss, ophthalmoscopy, growth of abnormal vessels in retinal space, sudden visual loss if complicated by retinal detachment. Ophthalmology, pediatrics vision assessment or screening. Vision assessment should be performed at every well-child exam during first few years to prevent permanent vision loss. During infancy, by observation, fixation and tracking, older infants and children, uncover test for strabismus, age 3 onwards, monocular visual acuity using Snellen's chart or tumbling E-chart. Visual acuity worse than 20/40 at 3 to 5 years or worse than 20/30 at 6 years. Rightward arrow. Ophthalmologic evaluation for refractive errors, abnormal red reflexes, misalignment, pupillary asymmetry of 1 mm. Corneal asymmetry, ptosis or other lesions obstructing the visual axis, and nystagmus are additional indications for referral. Strabismus can be intermittent or constant, ocular malalignment due to nasal deviation, esotropia, or rarely temporal deviation, exotropia. Watch video of cover test on YouTube. Intermittent strabismus can be expected in infants age 4 months due to immaturity of the extraocular muscles, ocular instability of infancy, rightward arrow. Reassurance and observation. Esotropia beyond early infancy must be treated to prevent amblyopia, vision loss from disuse of deviated eye. The first 5 years of life are extremely critical to the development of visual acuity, as it is the time for visual cortex maturation. During this stage, any anomaly, e.g., strabismus, refractive error, cataract, can compromise vision. Pseudostrabismus, provide reassurance. Trachoma, major cause of blindness worldwide. There is no text on this page. Caused by chlamydia trachomatis A, C, active phase, follicular conjunctivitis and pannus, neovascularization, formation in cornea. Concurrent infection occurs in nasopharynx. Rightward arrow. Nasal discharge, DX, GIAM. Sustained examination of conjunctival scrapings, RX, topical tetracycline or oral azithromycin. Start immediately. Repeated infections. Rightward arrow. Corneal scarring. Optic glioma in neurofibromatosis type 1, occurs in 15% PTS with NF, type 1, axillary freckling and CAF-O, less spots, occurs mostly in children. 6YRS, H/O. Slowly progressive U/L visual loss and dyschromatopsia. Exophthalmos sometimes present. Optic disc may be normal, swollen, pale, or atrophic. Retinal hamartoma typical of tuberous sclerosis. Retinoblastoma extremely high yield. Question. Every case of leukocoria is considered retinoblastoma until proven otherwise. Rightward arrow. Refer to ophthalmologist. Most common intraocular tumor of childhood, inactivation of tumor suppressor RB gene. Rightward arrow. Familial or sporadic, highly malignant. Rightward arrow. Delay in treatment. Rightward arrow. Mets to liver and brain. Rightward arrow. Death. Other manifestations, strabismus, downward arrow. Vision, ocular inflammation, eye pain, glaucoma, and orbital cellulitis, DX, highly suspected on US or CT findings of mass with calcifications. Presbyopia is a common age-related decrease in lens elasticity that leads to difficulty with near vision. A history of a middle-aged individual who has to hold books at an arm's length to read is classic. Hollenhorst plaque is a relatively common retinal finding in the geriatric population. Patients often are visually asymptomatic and present with retinal emboli from plaque ulceration in the internal carotid artery. BNS equals Doppler US contents salivary glands. 3. Sialidinosis. Sialidinosis. 3. Pleomorphic adenoma. 3. Oral leukoplakia. 3. Oral candidiasis. 3. Temporomandibular joint, TMJ, dysfunction. 3. Glossopharyngeal neuralgia. 4. Ramsay-Hunt syndrome. 4. Hearing loss. 4. Conductive hearing loss. 4. Otosclerosis. 4. Serous otitis media. 5. Sensorineural hearing loss. 5 presbycusis. 5 malignant otitis externa. 5 dizziness. 6 vertigo. 6 Meniere's disease. 6 allergic rhinitis. 7 aspirin exacerbated respiratory disease, AERD. 7 peritonsillar abscess. 8 nasopharyngeal carcinoma. 8 deep neck space infection. 8 retropharyngeal space infection/abscess. 8 Ludwig angina. 9 torus palatinus. 9 otalgia. 10 differential diagnosis. Diagnosis. 10 acute otitis media. 10 chronic suppurative otitis media. 11 cholesteatoma. 11 congenital. 11 acquired. 11 rhinosinusitis. 11 juvenile angiofibroma. 12 ent, IM oral cavity salivary gland sialidinosis. Benign, non-tender, non-inflammatory enlargement of salivary glands, causes, commonly in PTS with advanced liver disease, E.G. Alcoholic and non-alcoholic cirrhosis, also in PTS with altered dietary patterns or malnutrition, E.G. Diabetes, bulimia, associated with abnormal autonomic innervation of the glands, with accumulation of secretory granules in acinar cells. D/D, sialidinitis, focal tenderness, erythema, fever, salivary gland stones, glandular swelling and pain with meals, and malignancy. No management is needed other than to address any underlying nutritional disorders. Pleomorphic adenoma, benign neoplasm affecting salivary glands, present as firm nodule. Oral leukoplakia, reactive precancerous lesion that represent hyperplasia of squamous epithelium. Risk factors, same as those for squamous cell Ca, with smokeless tobacco, tobacco chewing, or alcohol use accounting for most cases. C/F, white granular patch or plaque over buccal mucosa, cannot be scraped off. Natural history depends on degree of dysplasia, with 1 to 20% lesions progressing to squamous cell Ca in 10 years, most resolve within a few weeks with cessation of tobacco use. The development of areas with induration and/or ulceration should prompt biopsy to rule out malignant transformation of the lesion. Oral candidiasis, risk factors, DM, immunodeficiency, use of antibiotics or inhaled glucocorticoids, C/F, white plagues on oral mucosa, tongue, or oropharynx with underlying erythema. Rightward arrow can be scraped off with tongue depressor. Temporomandibular joint, TMJ, dysfunction. Most PTS have AH/O nocturnal teeth grinding. PTS usually interpret pain as coming from ear worsened by chewing. Many have audible clicks or crepitus with jaw movement not seen in all PTS. Radiologic imaging is of limited use. Management, initial management, conservative such as nighttime bite guard. Surgical intervention is sometimes necessary. Glossopharyngeal neuralgia, intermittent, severe, stabbing pain in areas innervated by CN9-NX, which includes ear Ramsay-Hunt syndrome, form of herpes zoster infection, causes Bell's palsy. Vesicles seen on outer ear hearing loss. Conductive hearing loss, causes, cerumen impaction, middle ear fluid or infection, downward arrow movement of small bones of ear or bony tumor of middle ear. Otosclerosis. Common cause of conductive hearing loss in adults, typically in 20s and 30s, slight female predominance. Pathophysiology, abnormal remodeling of otic capsule, thought to be a possible autoimmune process in genetically susceptible individuals. The stapes footplate becomes fixed to the oval window, resulting in loss of its piston action. Sometimes referred to as otospongiosis, as CT scan may show a lucent, as opposed to sclerotic, focus in the temporal bone near the oval window. Low-frequency hearing loss, RX, hearing amplification or surgical stapedectomy. Serous otitis media. Most common middle ear pathology in PTS with AIDS, due to auditory tube dysfunction arising from HIV-LAD or obstructive lymphomas, characterized by middle ear effusion without acute infection, C/F, conductive hearing loss, most common feature, examination, dull, hypomobile tympanic membrane on pneumatic otoscopy, sensorineural hearing loss, presbycusis, disease of aging and usually first noticed in 6th decade of life. Although dis of aging, but many factors have been shown to influence rate of hearing loss, including medicines, genetics, H/O infections, and exposure to loud noise, begins with symmetrical, high-frequency hearing impairment. PTS often complain of difficulty hearing in crowded or noisy environment, trouble hearing high-pitched noises or voices. Malignant otitis externa, typically seen in elderly diabetic PTS, poorly controlled, or otherwise immunosuppressed PTS, most common cause, Pseudomonas aeruginosa, C/F, ear pain, typically worse at night, purulent ear drainage with sense of fullness not responsive to topical meds, and conductive hearing loss, fever, and elevated ESR, otoscopy, granulation tissue and edematous external auditory canal is characteristic. Progression: rightward arrow osteomyelitis of skull base, rightward arrow C and damage E.G. Facial nerve or osteomyelitis of TMJ, rightward arrow pain with chewing, DX, CT or MRI to confirm diagnosis, RX, systemic antibiotics effective against P. aeruginosa. 4. Ciprofloxacin doc for elderly PTS. In patients with fluoroquinolone resistant P. aeruginosa, alternate therapies include anti-pseudomonal penicillins or cephalosporins such as piperacillin and ceftazidime. Failure to respond to antibiotics: rightward arrow surgical debridement of necrotic tissue, not surgical excision, and biopsy to exclude malignancy. Dizziness, need to be classified as 1. Vertigo, spinning of room 2. Presyncope 3. Disequilibrium vertigo, classified as central, lasts longer than peripheral. Meniere's disease, abnormal accumulation of endolymph within inner ear, ear fullness, tinnitus, sensorineural hearing loss, rightward arrow preference of using cell phone on other ear, nose, allergic rhinitis. Conjunctival edema, or thick green nasal discharge may be present, intranasal glucocorticoids most effective, effect usually felt in several hours but maximal benefits require use for several days to weeks. Non-stating oral antihistamines, e.g., loratadine, ketorisen, antihistamine, e.g., azelastine or cromolyn nasal sprays, and leukotriene modifiers, e.g., montelukast, are less effective but can be considered based on the patient's symptoms and drug tolerances. Aspirin exacerbated respiratory disease, AERD, consists of asthma, chronic rhinosinusitis with nasal polyposis, rightward arrow recurrent nasal discharge and congestion, and bland tasting food due to anosmia, bronchospasm or nasal congestion following ingestion of aspirin or NSAIDs. DX, clinical when all above 3 are present. Examination should reveal presence of B/L gray, glistening mucoid masses in nasal cavity. Management: surgery provides temporary relief as polyps reappear. Ultimate treatment should be geared towards medical management of underlying etiology. Pregnant women have an increased incidence of pyogenic granulomas on the anterior nasal septum. These highly vascular lesions are frequent sources of nosebleeds during pregnancy. Throat peritonsillar abscess, complication of tonsillitis, fever, chills and sore throat. C/F, muffled voice or hot potato voice, difficulty swallowing, deviation of uvula, prominent U/L lad, U/L lad and deviation of uvula distinguishes it from epiglottitis, can be fatal to airway obstruction or spread of infection to parapharyngeal space, which may involve carotid sheath, rightward arrow erosion of carotid artery and jugular thrombophlebitis. Management: initial, needle aspiration of tonsillar abscess and initiation of 4 antibiotics. Surgical drainage if purulent material cannot be removed with aspiration alone. And surgery: nasopharyngeal carcinoma, undifferentiated CA of squamous cell origin, higher frequency in Mediterranean and Far Eastern population, usually asymptomatic until disease is advanced, usually metastasized by the time of diagnosis. SX, recurrent otitis media, due to obstruction of eustachian tube by tumor, recurrent epistaxis and/or nasal obstruction, strong association, positive serologies for EBV. The association is so strong that EBV titer levels may be used to track the progress of therapy for this malignancy. Other associations, smoking and with chronic nitrosamine consumption, as in diets rich in salted fish, deep neck space infection, they have become rare because of antibiotics, can spread rapidly and can be fatal. Retropharyngeal space infection/abscess, C/F, neck pain, fever, and limited neck mobility secondary to pain, difficulty swallowing, dysphagia, pain with swallowing, odynophagia. Trismus, inability to open the mouth normally, and limited cervical extension very common, source of infection, usually local penetrating trauma, which may occur after instrumentation or following an injury from a chicken bone. Complete evaluation of extent of infection, CT of the neck and/or lateral radiographs of the neck may demonstrate lordosis of the cervical spine with gas and swelling in the retropharyngeal space. Treatment, for broad spectrum antibiotics and urgent drainage of the abscess to avoid spread into the mediastinum. Complications, highest risk of spread to mediastinum, particularly anterior and posterior portions of superior mediastinum plus entire length of posterior mediastinum. Abscess can form in danger space, which is the space between alar and prevertebral fascia, and drain by gravity into posterior mediastinum, resulting in acute necrotizing mediastinitis. Early diagnosis and debridement of mediastinum essential in treatment of this severe complication. Ludwig angina, an infection in the submandibular space, also known as Ludwig's angina, typically begins in the floor of the mouth and extends through the submandibular and sublingual space into the tissue surrounding the airway. It does not commonly extend into the mediastinum. Sublingual space is a division of the submandibular space. As a result, an infection in the sublingual space is classified as a submandibular infection as well, which typically involves the tongue, palate, pharynx, epiglottis, and tissue surrounding the upper airway. Torus palatinus, chronic benign bony growth, I.E. Exostoses, located on midline suture of hard palate, can be due to genetic or environmental factors, more common in younger PTS, women, and Asians, usually 2 cm but can upward arrow in size throughout a person's life. Non-tender and chronic, thin epithelium overlying bony growth, ulcerates with normal trauma of oral cavity and heal slowly due to poor vascular supply. Management, surgery for those in whom mass becomes symptomatic, interferes with speech or eating, causes problems with fitting of dentures later in life. And pediatrics ear hearing impairment in children. Undetected hearing impairment can lead to poor language development and social skills. Children suffer from poor self-esteem, isolate themselves and apparent inattentiveness. Can be easily confused with pervasive and behavioral disorders of childhood, ADHD. Children with hearing impairment may be incorrectly diagnosed with ADHD. However, poor language development and social isolation are not features of ADHD. Repeated ear infections can result in conductive hearing loss, so screen them. Hearing tests should be routinely conducted in all children presenting with social or language deficits. QID 4050. Otalgia differential diagnosis. Acute otitis media. Uncommon complication of acute otitis media indicated by hypomobility of membrane on pneumatic insufflation, sign of inflammation, chronic suppurative OM, labyrinthitis, cholesteatoma, tympanosclerosis, eardrum perforation, most common in children 6 to 36 months, daycare exposure, and those around 5 years, school initiation, as their eustachian tube is short and easily clogged. Risk factors: formula rather than breast milk, exposure to cigarette smoke, allergic rhinitis or viral URTI, craniofacial anomalies, chronic middle ear effusion, RX. First line Rx, 10-day course of high-dose amoxicillin if PT returns within a month of initial Rx. Rightward arrow amoxicillin, clavulanate should be given in anticipation of beta-lactamase resistant strains. Empiric antibiotics usually adequate tympanocentesis and culture during myringotomy with tympanostomy. Tube placement should be considered in children with multiple episodes of AOM, e.g., /3 episodes within 6 months or /4 episodes within 12 months, despite appropriate antibiotic treatment. Observation is reasonable if child is /2 years, has normal immune system and SX are mild and U/L. Children who recover from AOM often have persistent effusion for weeks but do not require ongoing antibiotic treatment. Chronic suppurative otitis media, common pediatric problem. Typical symptoms include hearing loss, tympanic membrane perforation, and otorrhea for 6 weeks. It can be distinguished from AOM by lack of fever and ear pain plus prolonged duration of symptoms. Cholesteatoma, can be congenital or acquired. Congenital, usually in children around 5 years. Acquired, usually 2 to chronic middle ear disease. Rightward arrow formation of retraction pocket in tympanic membrane. Rightward arrow which can fill with granulation tissue and skin debris. Suspect in PT with continued ear drainage for several weeks despite appropriate antibiotic. Complications, hearing loss, cranial nerve palsies, vertigo, and potentially life-threatening infections like brain abscesses or meningitis. Refer to otorhinolaryngologist for dedicated otologic exam, possibly accompanied by CT and/or surgical visualization to confirm diagnosis. Nose rhinosinusitis, most cases are viral and can be treated by observation with follow-up, but if SX worsen or persist, treatment for bacterial should be started. If PTS develops complications like periorbital edema, vision abnormalities, altered mental status. Rightward arrow perform CT to identify suppurative complications. No role of X-ray for diagnosing sinusitis. Rx, oral amoxicillin, clavulanic acid. Doc covers S. Pneumonia and non-typable H. Influenza. Intranasal steroids may be added for PTS with H/O allergic rhinitis. No role of antihistamine, microbiology unnecessary in uncomplicated ABRS who improve as expected with antibiotic. If symptoms persist or worsen after 3 days of antibiotics, cultures should be obtained by sinus aspiration to better target antimicrobial therapy. Juvenile angiofibroma, any adolescent who presents with a nasal obstruction, visible nasal mass, and frequent nosebleeds, epistaxis, is considered to have a juvenile angiofibroma, JNA, unless proven otherwise. Typically found in the back of the nose or upper throat, nasopharynx, of adolescent boys. Benign growth, but capable of eroding and locally invading, potentially very dangerous because composed of many blood vessels which may bleed readily. Common areas of occurrence are difficult to access surgically. For these reasons, such tumors should only be touched by a specialist. Management, no treatment is necessary. In some cases Rx is required if it is enlarging, obstructing the airway, or causing chronic nosebleeds. Surgical treatment includes removal of the tumor, often difficult because the tumor is unencapsulated and may be deeply invasive. Recurrence of the tumor after surgical resection is common. Loop diuretics can cause reversible or permanent hearing loss and/or tinnitus. These ototoxic effects typically occur in patients taking high doses of loop diuretics, those with coexistent renal failure, or in patients who are also being treated with other known ototoxic medications, such as aminoglycosides. Contents: hospice model. 2 firearm injury. 2 brain death. 3 circumstances in which minors do not need consent. 4 performing procedures on deceased patient. Patient. 4 clinical features of possible child abuse. 5 social sciences hospice model. Firearm injury. Brain death. Circumstances in which minors do not need consent. Minor with emergency situation rightward arrow no consent needed mental health services, stable minor but life threatening condition and parents not agreeing to treatment rightward arrow hospital ethics committee, social services, and hospital risk management can also assist rightward arrow in some cases parents may agree but if they continue to refuse treatment rightward arrow obtain court orders to give treatment performing procedures on deceased patient, permission from patient before death or from family is must before performing procedures on deceased PT for training. If previously obtained consent from PT is not documented or appropriate family member is not available to give consent rightward arrow do not perform procedure. Clinical features of possible child abuse.